With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Welcome back to part 2 of my interview with Dr. Vincent Brandys. In this episode, Dr. Brandys discusses who are appropriate candidates for refractive surgery. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Something I've seen is something called corneal molding, where the patient, instead of seeing 20/20, is now a 20/30 patient and has bought one of these contact lenses by one of these over-the-counter online companies that they don't really examine the patient. They just send them contact lenses. And this is a patient who was wearing one of the regular contact lenses, a Bausch & Lomb contact lenses, was seeing 20/20, or they've been wearing a Johnson & Johnson or CooperVision or Alcon, one of the big companies that do a lot of research and development in contact lenses. But they saw advertisement and they tried one of these free 30-day trials, or paid a minimal amount. And they came in and all of a sudden they're seeing 20/30 and their cornea was distorted, because we could do aberrometry to see if there's distortions on the cornea. And this patient was seeing 20/30. And I thought that, wow, that's pretty interesting. And any corneal molding issues that you've seen that you could tell us about?
Yeah, absolutely. And it's been a while, but I wanted to educate the listeners who may not be providers. There are 3 types or 3 parts of a contact lens prescription. There's the power, of course, nearsighted, farsighted. If you have astigmatism, that would be a toric lens. And then there's something called the base curve, or BC. You'll see it on your box. And the base curve is specific for your cornea. And even if you have the same prescription as your wife, you may have a different base curve because of the way your eye is shaped. And then the DAI that's on your box, that's diameter, that's the size of the lens. And that also will play a factor into how the lens fits. And the corneal moldings that I've seen are the bigger lenses that patients are getting from a non-FDA approved company, and they're wearing them and they're actually molding the eye, just like it sounds. And they're actually distorting the cornea. And when we do topography, we can see these changes. And it doesn't necessarily need to be a toric lens, which would be a little thicker, but I think the patient doesn't realize by that substitution, in the one case that I can recall, the patient, when I showed her what the BC diameter meant, and she looked at the box of what she got from this online seller, they weren't even close. It was a steeper fit. It was a larger lens. And she started to see the changes. Thank God she came in before something more drastic happened. Her acuity wasn't that bad. It was 20/25, but she had some halos. So we got her out of that lens and kind of educated her. And last time I checked, she started a little blog, or has a blog, but added that to her blog about the dangers of using lenses that your doctor didn't prescribe.
Interesting. And if you know her blog, we'll be happy to put it at the end of the show notes. If you could mention it, if you could remember the name of it. Let's go to giant papillary conjunctivitis. That's something we should see a lot.
Yes.
And with single-use contact, we don't see as much, but we do see it every once in a while.
So GPC, giant papillary conjunctivitis, is the upside down. Your doctor will invert your lid and he'll look at the upper lid and see if there's these bumps. Now, it's not on the cornea. We talked about bumps on the cornea. This is actually on your eyelids. And those, the mechanical abrasion of the lens and lid get mucus buildup, and it's a reaction to the plastic, and it causes these bumps to grow. A lot of times, even when you switch someone out of contacts, it takes a long time to get rid of those. Dr. Gelb, you may remember chromium sodium, which is a drug that haven't prescribed in years, but there were other ways to inhibit that mast cell or that reaction, the allergic response that the patient was getting from wearing the old style of contact lens. But the way we treat it now is a daily lens. And sometimes the patients don't like to hear this, but they have to have a contact lens holiday. They need to take a break from wearing their contacts because it's that force that's causing almost like a scab or a callus. And that's not going to get better when you keep wearing your contacts.
And then there's corneal vascularization where blood vessels start to grow inside the cornea.
Yeah, that's a tough one for patients to understand. And thank God we have smartphones and video cameras on our slit lamps these days. And we can show the patient what that is. So again, cornea, transparent covering, the iris, the margin between the blue and the white part of your eye, the blood vessels will come from the white part and cross over into your iris. And it's corneal, in the cornea, neo, which means new, vascularization, blood vessels. So new blood vessels are growing into your cornea. Again, you don't know it, you think it's fine. And a lot of times it's a patient with no symptoms. It's a patient who sees well, patient who has no self-reporting issues or a health history. They've just been using contacts for so long, and their response to the way they're wearing those lenses, even if we switch lenses, is not a positive response. So again, we have to consider either taking them out of contacts, trying maybe a gas perm lens, or refractive surgery.
And this all leads to contact lens intolerance and also dry eye. So the difference between dry eye syndrome and contact lens associated dryness, how would you make that distinction?
So if a patient has dry eye, we will be able to evaluate it whether they wear contacts or not. But then there are the patients who have worn contacts for a long time. Now they're developing more dryness, and now it's becoming contact lens induced dryness. So we deal with it. There are individuals who suffer from autoimmune disorders like Sjogren's, and there are individuals who have hormonal changes, and that will affect their overall comfort. But what you have to do is start with the tear film, make sure you can get it as strong as possible, try to diminish inflammation. Now, when we graduated back in the day, Carrie, there wasn't cyclosporine drugs. Now, thank God we have them, because the only way we could treat inflammation in the eye is, the drug of choice back then was Predforte, but you couldn't put a patient on that long term. That's going to cause a problem. Spikes in their intraocular eye pressure and potential cataracts. So we wanted to make sure that we could diminish inflammation. And now with the 3 drugs that are out there, one of them now is generic. It's a great way to help the patient either stay in contacts or help the folks who aren't wearing contacts and need that drug to diminish the swelling and inflammation that they get in their eye.
And one of the causes of dry eyes is meibomian gland dysfunction. If you could explain the importance of the meibomian glands, and you referred to it a little bit when you went through the different parts of the tear layer and the oil layer, but explain about that and why do people get meibomian gland dysfunction and what could be done about it, and why does it cause dry eye?
Well, that's a revolutionary change in how we attack this problem. So the meibomian gland is in your lid, and in the lid, it creates this oil to protect and coat the eye on the anterior surface, the front surface. So what happens with contact lens wear, and it also happens with people who don't wear contacts, the gland itself stops producing and also can get clogged. So your provider can see if it's capped, if there's this substance over it. And so they can massage it and open it, and that will create this discharge. But now there are great technology that can analyze your meibomian glands. I'm holding my fingers up because that's exactly what they look like when we do the scan. And you can see if they're fully producing or if they're not producing at all. And there are ways now which we can treat that by using heat and other lights to increase meibomian gland production. Because when you don't create that and you have this issue, again, contact lens related and not, it's not going to get any better. And so MGD, as we call it for short, is probably the biggest issue with contact lens intolerance.
So if someone is contact lens intolerant, they're looking for other options. You know, they have to wear their glasses, or they might be a good candidate for refractive surgery. Tell me in general about refractive surgery, and are patients generally happy after they have refractive surgery? And if you compare refractive surgery versus happiness versus other modalities of vision correction.
So as I mentioned, I'm a refractive surgery patient for many years. My daughter, my sister, many members of my family, many patients of mine. I don't remember more than 5 patients, I think, certainly less than 10, who I referred for PRK. Partly because of the way the eye has to heal and the way the patient's post-op care is done. I mean, it's not a very comfortable way to have refractive surgery, which is why LASIK was invented. But with PRK, the surgeon breaks up the top layer, the epithelium of your eye, with an excimer laser. And by doing that, they flatten it. They're taking tissue off, and by flattening it, it's changing the light into your eye and giving you your full correction, hopefully. But sometimes with the recovery from PRK, if there's a infection, if there's long-term swelling, the cornea may not respond, and it may take longer for you to heal. LASIK came out in the late 90s, I believe 96, 95 in America, and LASIK creates a flap. It's a 270-degree flap where the surgeon then takes it back, treats the lower tissue, puts the flap back down. When I had it done, they used a blade, a microkeratome. Now, most surgeons use a femtosecond laser, intralace, to make that flap. A cleaner flap, a flap that probably will not have a lot of DLK, which is just a swelling inside the layers, almost a wrinkling of the flap. So most surgeons, those surgeons we work with, are using a microkeratome. I'm sorry, not using a microkeratome, using the intralace laser. And the latest.
Just to interrupt, because I want to get into that in more depth in a minute, but the refractive surgery patients, where are they coming from? Are they coming from contact lens dropouts? And what's the most common reason why people are dropping out of contact? Is it vision and dryness, or is it something else?
By far the most common, in my practice anyway, is contact lens intolerance. Not even close. It's because the patients, the ones who have always had glasses, and you talk to them about contacts and they're just scared, I don't want to touch my eye. When you tell them, describe the process of any of the refractive options, they're freaked out. And then you say, oh, will they put me under? No, you're awake. So then those individuals, sometimes they'll never bring it up again because they're just anxious about the process. And I haven't had many patients over my 30 years that have worn glasses exclusively and went to refractive procedures. So it's the ones who have had contacts, like the ability to see without having glasses, and want that back. But because of their MGD, from their hypoxia, from whatever the situation is, want that vision, but don't want to have to deal with the contact lens intolerance.
Okay, so let's take the different types of refractive surgeries and let's go into some detail. You alluded to LASIK. Tell us about LASIK. What kind of lasers you use? You have to use 2 lasers. How long does it take? And let's start off with, who's a good candidate for LASIK?
Well, number one, it's an age minimum. Okay, most surgeons we work with start at 21. I've seen patients go to other doctors and get it at 18. But you want stability. So you could be 25, but if your vision keeps changing, it's like the old rule of carpentry, Carrie. We measure twice, cut once. We want to make sure that your vision, whatever is going to be put into the software to calculate the best prescription to get your vision postoperatively back to where it was when you had your contacts and glasses on, we want to make sure that we have your stability over at least a 12-month period, sometimes longer. Individuals who are pregnant or who want to get pregnant should probably wait to start their families and then have refractive surgery done. Individuals who are not healthy, I talked about autoimmune disorders, diabetics. I'm not saying you can't have it done, but you would need a co-management work with the workup with your rheumatologist or your endocrinologist to make sure that when you do this, is it something that they state that your A1C is controlled or your ANA on your lupus is controlled, where they feel like you can go ahead and take the risk. And finally, I think it comes down to just that, risk and reward. Remember, even the greatest surgeon with the most experience is still a human being. It's a computer, it's a laser, and you want to make sure that you go to someone who's experienced, but there is a risk involved. Now, I personally have never seen a patient who's lost vision with their post-op LASIK. And when I mean lost vision, I mean complete darkness. I don't think many of us have, but they've lost best corrected vision. So that's the risk you're taking. So in LASIK, when they make that flap and they put it down, there's no sutures, there's no stitches, there's no patches. So it has to regrow. And just like your little cut on your finger is going to regrow, the tissue has to regrow. And if the flap dislodges, and there's been documented cases of the flap moving from rubbing the eye or airbag deploying, sports activities causing that. That's the key after LASIK. You still, years later, and I'm, many years later, 24 years after my surgery, I still am very careful around potential ways that a flap can get dislodged. So what we want to make sure is the patient understands there's always a risk. And if your vision was 20/20 with your glasses on and your contacts, and you were 2400 without them, the goal is to get you back to 20/20. Now, unfortunately, I've seen patients who ended up 20/30. Well, 20/30 is a heck of a lot better than 2400, but they've lost permanent vision, best corrected vision, and that's the risk you take when you consider refractive surgery versus staying in your contacts.
So when you have LASIK, you need two different lasers. If you could explain that part of the procedure a little bit.
So in LASIK, nowadays, I'm sure it's done somewhere in America, but most use a femtosecond laser. That's the laser that creates your flap. And then when they take the flap back and they treat the underlying bed of tissue, that's an excimer laser. And the excimer laser is ablating tissue, flattening it. You actually, when I had it done, I could hear the little pop, and you can even, there's a distinct smell too, not bad, but it's definitely, you can hear the tissue being changed, and then they put the flap back down. From my patient point of view, I think it took 40 seconds, start to finish. There's more prep time, and the issues that you have afterwards pretty much go away within a few days. You'll be given medications to deal with your post-op swelling and prevent infection. But for me, LASIK was a godsend. I love my vision, and I'm very grateful for it. But those two lasers are the key to giving you best vision. And I still today tell the patient, I had a relative ask me for a recommendation in Topeka. I don't know a surgeon in Topeka, but I said, make sure they have a lot of experience. They've at least done 10,000 refractive procedures, and that they're using two lasers for their LASIK. If they're still using a blade, do not go to that surgeon.
Explain why you have to make a flap.
So in PRK, there's no flap, and that again was the same end result, but there was a lot of pain. You're going through corneal nerves in your eye, and that was, they thought, and still probably is, if you have a very thin cornea, we'll do a measurement on you. It's called pachymetry, and we're going to measure your corneal thickness. If it's a certain, level of thickness that is minimum, you can't get LASIK. So PRK is your only option. I've had a couple patients, even one last year, had very deep set orbits. And so, they were very skeptical about doing that. But nowadays they don't use microkeratome, so that shouldn't be too much of a problem. But the level of correction with the flap is, it's almost making a band-aid. So the surgeon's making the flap, so when he or she puts it down, it's gonna not have that pain and nerve debilitating feel with burning in your eyes that you will if you do PRK.
So PRK, you're just using a laser, but you have to scrape the front surface of the eye, the epithelium.
Yep.
So that has to heal, and that's certainly a lot. There could be some pain involved. When
Yes.
you're doing LASIK, you're getting to what we call the stroma, the tissue that needs to be vaporized, just by making this flap, and then by pushing it back down, it'll heal easier, and it's a much more comfortable recovery. But you may not be able to treat as much of a prescription because you have to make that cut into the cornea, so less of the stroma is exposed. Is that correct?
That is exactly correct. And I think the individuals who have, you remember, the more tissue you take, or the higher your prescription, the more tissue has to come off. And so there are individuals who are highly myopic, 7, 8, and 9. In the early days of LASIK, surgeons were getting a little more aggressive. Now they're more conservative. There's another procedure out there too, but I mean, even in general, before SMILE was invented, some surgeons were going as high as -9 and -10 if the patient had nice thick corneas. But again, it's still more of a risk because the flap and the combination of the tissue underneath has to heal. If there's any swelling, if you get any issues with how the vision ends up after your surgery, sometimes we have to send the patient back, and the technique is called float the flap or refloat it. So the surgeon will lift the flap, clean any debris that might be under the lens, or I'm sorry, under the flap, and place it back down. Now the healing starts all over again. But that's something that if it's obstructing your vision, one of the things I learned early on is if I had any debris in a patient, if it was out of their zone of their visual axis, sometimes, believe it or not, it'll actually move away and continue sometimes to go off the axis and stay off the axis. If it's right over, you can't wait. You have to send the patient back. So a complication for the patients who are considering it is when you are healing, if you start to see distortion, start to see halos of light that you didn't see before, that's probably your flap swelling.
So the higher the prescription, the more tissue you have to remove or vaporize, the greater risk of something called ectasia. Explain what ectasia is, and that's something that we're very worried about.
Yeah, ectasia, before we had the technology to examine the full thickness of the cornea, one of the conditions that early on we weren't able to, with topography, 100% identify was keratoconus. So kerato means peak, kerato means cornea, cone means peak. And so it's a peaking or you're thinning of the cornea and it's pushing up like this. And again, there are special contact lenses, hard lenses, scleral lenses that we can fit, sometimes even a hybrid lens. But if you're an unidentified pre-cone, as we call them, or afterwards you get a LASIK procedure done and you have ectasia, your vision is permanently changed. A lot of times there's not much the surgeon can do. And so the patient comes back to us wanting to get the best refraction possible and potentially getting fit into some type of specialty lens, depending on how well their cornea integrity is. But that is a very important concern. And that's why the post-operative care is key. But I think pre and selection of who you're going to do LASIK on is more important than anything we can do afterwards.
Yeah, because if the patient gets ectasia and they get this distorted cornea, they're very unhappy, and their only treatment really is some very sophisticated types of contact lenses. So the patient doesn't get the outcome they want, and now they have to wear these very expensive contact lenses that are difficult to wear. So that is a side effect of LASIK. That's one of the reasons that the surgeons aren't doing such high prescriptions anymore, because that's something they're very concerned about.
Absolutely, because they're an unhappy patient, and like you just mentioned, it's not a simple lens. Most cases, you need to fit that patient in some type of rigid hybrid or scleral lens to try to get them the vision that they want. And if this patient is over 40, oh, that's even worse, because now they have presbyopia and other issues, and they have inconsistent vision. And now we have someone who probably had contact lens intolerance. So now you're making it worse because they got to still wear contacts.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
There's also a risk of having severe pain after LASIK. It's very rare, but it can happen.
Yeah, I haven't had one patient who really had a complication, and but again, it was a patient who didn't listen, and he decided to use a hot tub, a public hot tub, and he had epithelial ingrowth from a bacteria that he admitted he dunked his head in a public hot tub. That's not a good idea if you have LASIK or contacts, or even if you wear glasses. Don't dunk your head in a public hot tub.
Yeah,
Public service announcement for the day.
So people are concerned that if they sneeze during the LASIK procedure, that it's gonna get they're gonna get the wrong treatment. What happens if you sneeze during LASIK?
Well, besides the surgeon having an increase in his blood pressure and pulse rate, you have a when you're in the operating suite, you have a lid speculum that is placed in your eye. Most surgeons use Valium. So you're given Valium to kind of take the edge off. You are not under general anesthesia. Unlike cataract surgery, most surgeons do bilateral procedures, whether it's PRK, that's a little more aggressive, but certainly LASIK, it's done bilateral. The newest procedure, SMILE, bilateral. So, but that means both eyes are done. You can get a break in between eyes, but they're going to switch this switch the lid speculum. So when you're there, they place it. So if you sneeze or cough or move, they're not going to be happy with you. So they'll reassure you, and they'll make sure that the staff is reassuring you. A lot of times, again, the surgeons we use, they actually have one staffer whose job is to sit next to the patient and hold the patient's hand and reassure the patient everything is going smoothly. Sit still, look at the light. Try not to blink. Try not to think. Just it happens so quickly that the only part of LASIK that I think personally was scary for me is when I blacked out. And I don't mean black out like I passed out. The pressure in the eye to make the LASIK microkeratome, to make the eye rigid for them to create the flap, they have to increase the pressure in your eye. And the optic nerve then, for literally seconds, blacks your vision out. It comes back immediately. But make sure you as the referring doctor educate your patients what's about to happen, because that is something that is definitely a little frightening.
And the laser tracks your eye 1,000 times per second. So if you move or something, it could shut off, and it'll follow you. So if you sneeze, you don't really have to worry about it.
Yes, I mean I've never had a patient had that problem, but yes, or cough for that matter too. I mean there's a check and fail safe way of not making a bad outcome just because you had a sneeze or a cough.
And how about the post-op with LASIK? So you have LASIK, you're back to your optometrist. What should you expect?
Depending on how well the surgery went, your vision, using an example of 2400, when you leave the OR suite, they're going to check your vision. They're going to make sure the flap is centered and that your eye, you might have what we call subconjunctival hemorrhages. On the white of your eye, you'll see these little like red blotches. It kind of looks not like red when you rub the eyes, but or like little vessels, but like a collection of blood vessels. And that's because your pressure was built up when they were doing it. And so you'll see this redness right away. Don't panic. It's not a bad thing. It's not an infection. And you're probably going to be vision, if it's a good outcome, you should be 20/30, 20/40 right away before you leave the office. And then when you come to your optometrist the next day, you should definitely follow the instructions. Some surgeons use a different matrix of drops, but follow what they're recommending. Take the drops as indicated. What I did, which was I think key for my recovery, is I went home and I took a nap. I did wear little goggles. They give you just a little protective goggles for the first couple days. Even if you sleep alone, you should probably wear the goggles. You may rub your eye or flip over, or your pillow might hit it, and that can move the flap. You're pretty feeling good. There's not a lot of pain. And then when your optometrist sees you on the next day, you may not be 20/20 yet, but as long as your flap is centered, he'll see you or she'll see you again in a week and continue to monitor your progress.
Let's talk about the next procedure, which is really exciting. It's a procedure that many of the Army combat personnel are opting for, a lot of the police, because athletes, because you don't need a flap. It's called SMILE. And if you remember what SMILE stands for, you could tell us what that is. And tell us, what is SMILE and what's the difference between SMILE and its advantages or maybe disadvantage over LASIK?
So the surgeons we use, ironically, are in a medical building, and they're on the 3rd floor. And they're one of 2 practices in Chicagoland area who are now doing SMILE. On the 2nd floor is a dental practice. So when you walk in the elevator, you punch SMILE. That's the name of the dental office for the 2nd floor, except the cornea specialists are on the 3rd floor. So I find that amusing that it's the same name, but SMILE has nothing to do with your pearly whites or your teeth. It's called small incision lenticular extraction, SMILE. And it's a different procedure, like Dr. Gelb said, because it doesn't create a flap. And you're correct. Our military, our aviators, this week, Top Gun's coming out. So those people who have to fly at high speeds and G-forces were potentially at risk for that flap moving. And so we all want pilots as taxpayers to have great vision, but there are the other individuals who are involved in aviation. If they need, not contacts, if they need to see, SMILE is an option, as well as our combat personnel. So if you do PRK, they're going to be out of, going to do anything in the military for at least a week, probably more like 3 to 4 weeks, depending on how well they heal. SMILE, you don't have that. It's a much quicker recovery. I've already referred 3 patients to have it done. All have been successful. One of them was 66 years old. Got tired of her gas perms. The thought of getting cut with LASIK just freaked her out. And finally, she made the big jump and had SMILE done about a month ago. And she was a moderate myope who's going to wear glasses afterwards. She did not want monovision. We tried that. So SMILE has the best of LASIK without blacking you out and causing potential subconj hemorrhages, the redness that I talked about. And it also will give you, the patient, who may have been disqualified or didn't qualify for LASIK, because the parameters of SMILE are a little higher in terms of what the surgeon can correct for.
Explain to us the procedure, how it works.
So it's a different laser. It's called the Visumax. And so what it does is it ablates tissue. There's an excimer tissue that when they're flattening in between the cornea, there's layers, and they flatten that area. And so when they break it up, when they make an incision, it's typically a 3 to 4 millimeter incision, then the surgeon opens that area that was cut by the laser and pulls it out like a wafer. And so it effectively flattens. So think about an Oreo cookie where you have the 2 layers, they pull this part out and the layers come down and touch. And because they're flattening the eye, the procedure itself isn't as invasive as LASIK and certainly not as invasive as PRK.
And they're using a femtosecond laser instead of an excimer laser. Is that correct?
That's correct. Yep.
And how do they know how much of the tissue to remove?
There is a formula or nomogram that they've been using. It's been done since 2018, I believe, here in the States, but it's been longer overseas. And in this area, like I said, there's 2 surgeons that have been doing it since the end of last year. And it's more intense of a surgical skill. Not that any surgeon could do PRK, any eye surgeon can, but the level of experience in PRK, not so important, definitely more important in LASIK. And I think from the observing it and from seeing patients 3 now postoperatively, it's the surgical skill. And obviously these surgeons are still learning the procedure, but the way you have to make the incision and find the anterior and posterior plane, the front and the bottom of this wafer, takes some skill. And I always have said to patients, again, who want a referral for a practice outside of Chicagoland, I personally recommend any refractive procedure done by a cornea specialist. And if you're in an area they don't have one or you can't find one, you want to go to someone with SMILE who does a lot of cataracts, because it's a similar hand-eye coordination to make sure that they're doing it correctly. And timing is important too. You don't, the longer you stay in the eye, the more inflammation. So you want to make sure that your surgeon is skilled to handle any potential complication. But the bottom line is, after you get the procedure, your recovery is faster in most cases, and you don't have the same side effects that you would for PRK or LASIK.
And there's a less risk of scarring, I understand.
Yes, definitely, because again, there's no flap. The flap again was 270 degrees. Now they're making a 3 millimeter to 4 millimeter opening to get that wafer out.
Now we do a technique all optometrists do where we measure the thickness of the cornea. It's called pachymetry. Now, is SMILE better with the thinner corneas?
That is a question for a corneal surgeon. I'm not trying to deflect here, but I would say yes from what I know, but it depends upon the patient, the prescription, the age. There's a whole host of factors, but in general, I guess I would say yes.
And the opening to remove that wafer of tissue is how big is that?
3 to 4 millimeters. Sometimes they go a little larger, but I believe most surgeons are doing a 4 millimeter flap, or not flap, a 4 millimeter opening.
And how are they removing that wafer?
With forceps, just pulling it right out.
They're just pulling it out.
Mm-hmm.
And how long is the recovery where people can start to see well?
Faster than LASIK, and that's been documented by an independent study in terms of comparing LASIK and certainly PRK. But I think the study was more LASIK versus SMILE. And again, because it's, I'm not going to say a self-contained structure, but think about it, you're cutting all this versus just this little area here, and the chance of infection, the chance of inflammation is reduced.
And what's the follow-up as far as drops goes to follow the patient?
Well, I actually got the chance to observe a surgeon in Naples, Florida, and I was there on a Friday. And so he has optometrists working with him as well. So I made the joke and I said, which one of your ODs has to come in tomorrow to see this patient? Now he's done a lot of SMILE. He's probably at that point, he was over 300. And he said, this is so much easier than LASIK. No one. I said, what do you mean? He said, unless the patient has some unusual issue during the surgery or after, we won't see the patient till Monday. And he does all his SMILEs on Fridays. So the recovery is faster. Obviously lubrication, antibiotics, and anti-inflammatory medicine, eye drops are used. But he has done, what he does, which is kind of unique. So remember the wafer I was telling you about? What he does is he has his staff take the wafer out, they put it on a piece of like cardboard, and they put fluorescein on it. So your souvenir, like when you go to your dentist as a kid, you get your teeth, you have orange circles of the wafer that you can, I don't know, put on eBay or something. But he actually gives his patients the orange wafer after surgery.
Interesting. Now, can this be done with people that are farsighted, or is it just for nearsighted?
Just for nearsighted now. And there's a certain level of astigmatism as well. So the parameters, off the top of my head, I don't remember exactly, but I believe it goes up to -10 of your degrees of diopters of nearsightedness. And I believe astigmatism is -2.
And side effects that we need to be concerned about?
I'm not aware of any. I mean, again, it's the healing time. I think it's more, as we talked about, it's always a pre-selection. You want to make sure that the patient understands that there's risk. And I think if you're deciding between the two and you are maybe someone who didn't think about LASIK because you didn't like the fact of a cut, talk to your doctor about SMILE.
And so let's move to PRK, or photorefractive keratectomy, to treat nearsight, something that's not, we talked a little bit about it before, it's not used as much. When is it a time to use PRK? The older fashioned type surgery where you're scraping the whole front surface.
I believe it would be for thinner corneas as well. But again, because of the recovery time, I don't know how many referrals for refractive surgery patients have actually had it done, but I want to say it's probably less than 5 or right around there. I'm not a big proponent of PRK. I mean, if that's the only option for the patient, great. And I believe it was one young man who wanted to go to the military and he was applying to get in to one of the academies. So he had PRK before he went in.
And PRK was done for athletes, so you don't have a flap. Is that something we could use SMILE for instead?
Yes, absolutely. The small incision that I'm referring to keeps the eye more stable.
Now let's talk about people that have very high prescription and we have to use implants, almost like a cataract implant. If you could speak a little bit to that.
So when you have the lens of your eye and gets cloudy, that's called a cataract. And then you get a plastic implant put in its place. There are individuals who still have their lens. It's clear. It's not cloudy or anything. They're young, but their prescription might be a -18. They're high myope. And then what the surgeon will do is actually put an implant in front of your lens to try to ICL, to try to get all of the correction afterward. Sometimes they might have to do an RK cut. Sometimes they will do LASIK afterward. It just depends upon how much of the anterior chamber depth you have in order for them to calculate the correct power. And that's, again, a very surgical dependent procedure. That's someone who either is a cornea specialist or someone who is very versed in cataract surgery. Not a lot of general ophthalmologists are doing ICL.
And the side effects to that, do we have to worry about the implant touching the lens and causing a cataract?
Yes, and it also can cause an iritis, depending on how the lens is placed and how the patient recovers. Again, your health is important. So if you're someone who has inflammatory markers, you're probably not a good candidate for an ICL.
Before we mentioned about ectasia, which is a thinning of the cornea, and we talked about it in terms of LASIK. But how about in terms of PRK or SMILE? Is ectasia an issue for us?
Ectasia is always an issue. I mean, I think what you want to make sure, well, the surgeons will make sure, and you, if you are working with a surgeon and you have topography and the ability to screen the patient appropriately, ectasia is something that you want to rule out for all three, but more specifically for the final or the second two, PRK, I'm sorry, LASIK and SMILE.
And is there a greater risk of ectasia with PRK, LASIK, or SMILE? I know there's been some studies on it, but we really just aren't sure yet.
I'm not versed on that well enough to give you a confident answer. Obviously, there's been many cases, unfortunately, of ectasia with LASIK, and I believe the screening process with that is improved with SMILE, but I honestly do not know.
And let's look into the future a little bit. What do we see for the future for refractive surgery? And how about presbyopes, people over the age of 40 that can read, that are looking for some type of refractive surgery?
Yeah, that's an interesting new frontier. I think folks may be aware of there's an old eye drop called pilocarpine that has been reformulated and now has been marketed for the beginning or emerging presbyopes between 35 and 50 who might benefit from getting an improved vision or depth of field with this new drop. But as the baby boomers are graying, I'm the last year of the boomers, and now we have our next generation of wave of presbyopes coming. Those individuals like seeing with their contacts, and they don't want to wear reading glasses over it. And there are patients who just can't do monovision. And a multifocal contact sounds like it's from outer space for some people. So trying to correct a presbyope, to me, there's nothing worse than that low hyperope who becomes presbyopic and is just beside themselves. Like, they did something wrong in their life and this is someone up above punishing them. They just don't understand. Like, I've never had to wear glasses. Why do I need to wear glasses now? I hate to wear glasses. And you try to explain it to them. So if there could be a procedure, which they're experimenting with several different options, most involving the lens and the ciliary body to get that patient stability, that would be a significant market for them to address. And of course, we have multifocal IOLs, implants, that people who are after cataract surgery for many years, it could get monovision cataract surgery, not done too much. Most times it's correcting your distance, and then you need glasses afterwards to read. Now with the multifocal IOLs becoming more popular, individuals, for the most part, I never tell a multifocal patient, implant patient, that you're never going to wear glasses. That's a mistake. So if your doctor is telling you that, they're not being honest with you, because depending on how well the surgery goes, depending on how well your outcome is and your day-to-day life. If you're 65, still working full-time, and your woodworking is your hobby, chances are you're still going to need reading glasses to see that small stuff. If you're a little older and you don't have that visual demand up close, multifocals may be the only option for you, but you don't need glasses because you're not really having that same demand as the younger patient.
Have you seen any patients that had the surgery where they put that disc in the cornea with the pinhole? Like, as you alluded to, the new drop Vuity that's being made, but they actually had a surgical procedure for presbyopia by putting a pinhole disc in one of the eyes.
No, I haven't seen that. And the surgeons that I work with are just starting to do, or will start to do, I think next month, LAL, the light adjustable lens, which is again for presbyopia and adjusting that. And the one practice here, one practice here in Chicago, it's the OD that's doing it. They're the ones adjusting the power after surgery.
So they're using the light, the UV light, to adjust the power. Interesting.
Yep.
That's going to be something that for us to look forward to. The technology changes so quickly every couple of years. It's almost the profession is reinvented. So we live in a great profession, and we're lucky to be part of it.
Yeah, and for you patients out there listening, if your eye care provider is not keeping up with technology and not offering you suggestions and potential new products and new ways to correct your vision, find someone who will.
So, Dr. Brandys, is there anything that I left out that you'd like to tell the audience before we close the interview?
Yeah, Carrie, I would. I think we need to think about our eyes connected to everything else. I know your fantastic movie, Open Your Eyes, started to increase the discussion about that. But when a patient comes in, and I had one yesterday, they're on Ozempic and metformin. I'm not diabetic. Okay. Yes, you are. No, I'm pre-diabetic. What's your A1C? Oh, I don't check that. No, you don't check it. Your doctor does. What's your daily? I don't. I'm too busy. So you got to remember that your eyes are connected to your body. And while we can diagnose glaucoma and other eye-related things, you need to make sure that your body's healthy. So you can't expect to have great vision into your 60s, 70s, and 80s if you have medical problems. So proper diet, nutrition, exercise, taking care of yourself will help your vision. And I always tell patients, the number one cause of blindness, in my opinion, it has nothing to do with the eye per se. It's diabetes, it's wicked, and it will cause so much damage to your body, but especially your vision. And it's controllable to the extent that you're willing to work with your endocrinologist and your physician to control your glucose levels and other aspects of the condition, because it's not just going to affect your eyes, it'll affect your feet, circulation, as well as cardiac and respiratory. So take care of your body, and the eyes will go with it. And hopefully you'll see well into your 80s and not necessarily have any other complications, maybe cataract surgery when you get that point.
Dr. Brandys, thank you for sharing that. There are close to 300 systemic diseases that can manifest in the eye, and many times the eye doctor is the first one to diagnose this. As I always say, the eye bone is connected to the toe bone. And I just really appreciate you coming on the show today. You're a wealth of knowledge. You have a terrific personality, and I really enjoyed our conversation. And I just really want to thank you for being my guest today.
Oh, Kerry, it was my pleasure. I appreciate the time, and hopefully the folks listening. And if there's any questions for me per se, you can definitely reach out via my Gmail account, and I'm sure Kerry can post it on his website, and I'd be happy to answer them. It's really important for patients to understand how important their vision is and what they can do to protect it. So thank you once again.
So let's do that now. So if somebody wants to find out more about you or contact you, how can they do that?
My first initial is V Brandys. My last name is BRANDYS, the number 23 at Gmail. So vbrandys23 at Gmail. And if you can, just put in the subject line, open your eyes or Dr. Gelb, so I'll know it's reference to this podcast. And I promise I'll get back to you.
Well, Dr. Brandys, thank you for joining me today. This is Dr. Kerry Gelb for Open Your Eyes.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.